Coming to GIT manifestation, firstly, portal hypertension. How is portal vein formed is by union of superior mesenteric and splenic vein. Okay. Portal hypertension is defined when the hepatic venous pressure gradient, that means pressure gradient between your portal vein and hepatic vein is greater than 5 mmHg. So depending on the gradient, we'll be grading the portal hypertension, and the results like portosystemic collaterals or your variceal bleeding also depends on the pressure. If the pressure gradient is greater than 8 to 10 mmHg, there will be formation of portosystemic collaterals. We'll see them. Firstly, esophageal varices, in that the portal component is your left gastric vein and short gastric vein, and systemic component is a zygous vein. Next, caput medusae, in that the portal component is your umbilical vein and systemic is epigastric vein. For rectal varices, rectal side, what will be having hemorrhoidal veins and middle inferior rectal veins. And the fourth one is your retroperitoneal collaterals. What are the complications of portal hypertension are your variceal bleeding, ascites, splenomegaly, liver failure, HRS, CVS and CNS manifestations. How does portal hypertension occur? Is firstly, in cirrhosis there will be fibrosis. So there will be resistance to portal venous flow. So there will be increased portal pressure. So portal hypertension occurs. This portal pressure is transmitted to splenic vein and causes splenomegaly, and also to relieve the pressure there will be formation of portosystemic shunts. Okay, for everything the cause is your cirrhosis, the fibrotic nodules increase in resistance to portal flow, then portal hypertension. To relieve that, there will be formation of collaterals. Okay, so the grading is grade 1, the gradient is between 5 to 8, grade 2 8 to 10, grade 3 10 to 12, and greater than 12 is your grade 4. So, individual manifestations, your ascites. This occurs if your pressure gradient is nearly 12 mmHg, 10 to 12 or 12 mmHg. So, we have to differentiate the ascites of hepatic cause with non-hepatic causes like renal disease, cardiac failure, malignancy, pancreatitis, your tuberculosis, etc. How we will differentiate is we'll do paracentesis and see serum ascites albumin gradient. If it is greater than 1.1, it is almost portal hypertension. That means it is of liver cause, up to 92% accuracy. Then what we'll do, we'll restrict salt, we'll give diuretics, and we'll correct hyponatremia, but in a serial slow manner, because fast and rapid correction will lead to your central point and myeloneurolysis. But even with salt restriction, diuretics and paracentesis, the ascites did not regress. That means it is refractory. And this refractory ascites is your hallmark complication of type 2 HRS. Okay. So that means the disease is severe, and what we'll do is we'll go for serial paracentesis, liver transplantation, tips. But for tips placement, you have to keep in mind that there will be again hepatic encephalopathy as complication. And finally, peritoneal venous shunt. It is an older intervention, but if the patient is not able to move for your serial paracentesis, and if he is not a person for transplant and tips placement, then it is the only choice left. Then we'll do peritoneal venous shunts. And firstly, while draining the ascites, if the fluid is less than 5 liters, it is okay. If it is greater than 5 liters, after 5 liters, for every liter, we have to replace 6 to 8 grams of albumin. Okay, for after 5 liters, for every liter 6 to 8 grams. Okay. Now we have taken the ascitic fluid. We have to see for the presence of infection, because we have to diagnose or rule out your spontaneous bacterial parasites. So in the that fluid, if the PMN count is greater than 250 cells per mm cube, in the absence of other sources of infection, it is SPP. So how we'll treat is your broad spectrum antibiotics. Of course, we'll send for cultures, but we won't wait for culture report. We'll be giving broad spectrum antibiotics. Otherwise, gradual and rapid, not gradual, it's rapid development of sepsis occurs. Okay, and this is a precipitating cause of HRS type 1. So HRS type 1 is associated with SPP. whereas HRS type 2 is refractory ascites. So what are the complications or your anesthetic implications for ascites are? Is ascites is a full stomach. So we have to do rapid sequence intubation and the intra-abdominal pressure is increased. Again the same thing, diaphragm is pushed upwards, FRC decreases, there is atelectasis, there may be rapid desaturation. And there, due to this ascites, there will be associated sepsis and hepatic hydrothorax. So those complications will also get added on. So this is on a whole. There is cirrhosis, increased resistance, portal hypertension. We have already seen that. Splanchnic vasodilatation. For this vasodilatation, there will be activation of vasoconstrictors. So there will be sodium and water retention, renal vasoconstriction, which is compensated initially by prostaglandins and later it will land into hepatorenal syndrome. And increased capillary pressure due to splanchnic vasodilatation causes lymph formation that exceeds lymph return and this causes ascites. So this is on a whole formation of ascites, your HRS, everything. Coming to varices. Again, from the starting, there is cirrhosis, increased portal pressure, there is altered architecture of the liver, and there is fibrosis and regenerative nodules. This causes a problem to the splanchnic flow, and there is a formation of portosystemic collaterals to relieve that increased portal pressure, and also there is production of vasodilators. There will be splanchnic vasodilatation. There finally there is formation of varices. We have seen esophageal varices, portal and systemic component of them. So, if the pressure increases, there will be rupture of these varices causing variceal bleed. It is the most lethal complication also. So, how we will diagnose this? We have to see the pressure gradient. It is around again 10 to 12. And the main gold standard is esophagogastroduodenoscopy. During that scopy, we will be seeing the varices and how they are about to rupture or ruptured varices and all will be seen. So what are your concerns is the patient will be hypovolemic and hypotensive. And also he might be in an uncooperative state because hepatic encephalopathy might be there. He might be in agitated state or very much drowsy state leading to coma and there will be aspiration and he is a full stomach patient and also other complications of cirrhosis like your decreased blood pressure due to other reasons also apart from the blood loss. So how we'll treat this? We'll go with non-selective beta blockers because we will have both beta 1 and beta 2 effects. Beta 1 decreases the cardiac output and beta 2 splanchnic vasoconstriction. This is your primary prophylaxis. If this beta blockers are contraindicated, we'll be going to endoscopic ligation, injection of sclerosis, and monopolar and bipolar coagulation, application of clips and tips. Tips is not considered because it is again more chances for encephalopathy. What we have to do if there is not acute variceal bleeding, that is for prevention or later treatment for variceal bleeding. Now, if it is acute variceal bleeding, first we'll see about volume resuscitation, blood resuscitation and all. But we have to be cautious because if we give more and more of volume, there will be more and more bleeding too because bleeding is a pressure related thing. So we have to be cautious and also see that the coagulopathy is improved and HB is around 8 grams. Don't overcorrect. Okay? And we have to see for your airway protection, we have to see the GCS and all and if needed, we'll intubate the patient. Pharmacotherapy, again, if needed, we'll go for vasopressin and it unlocks, but MI can occur, so we'll be giving NTG also parallelly depending on the BP and we can go for somatostatin analogs, but beta blockers, we should be careful because it might cause hypotension. And we'll go for early endoscopic variceal ligation. If the situation is worse, if the pressure gradient is greater than 20 mmHg, all the standard therapy won't work. Then we have to go for balloon tamponade. Again, the balloon tamponade may have the complications like esophageal rupture, necrosis, perforation and all. And if that also doesn't work, we'll go for surgical shunts or tips. Okay. So this is about variceal bleeding and its treatment, both anesthetic part and the general part. And so till now we have learned the manifestation of cirrhosis and hematological manifestation, CVS, CNS, GIT and renal. Miscellaneous manifestations might be there, which include endocrine system. There will be hypoglycemia. Of course, we have seen it priorly in liver function tests. Okay. This hypoglycemia is due to impaired glycogenolysis, gluconeogenesis, and decreased metabolism of insulin. And coming to hepatoadrenal syndrome, this should be treated by steroid hydrocortisone. In this, there will be disruption of HPA axis and there is lower mark. And coming to metabolic abnormalities, there might be as acid-base and electrolyte abnormalities which have to be corrected in an ICU or pre-op patient. So this on a whole is your cirrhosis, all the organ systems, their effects and anesthetic considerations. This we have already learned. This is a gross overall outlook. Okay.